Prynhawn da a croeso i gyfarfod rhythwyr Bwrdd Ymddiriedolaeth Gwasanaeth Iechyd Genedlaethol Brifysgol Velindre. Good afternoon and welcome to the Velindre University NHS Trust Board's meeting held in public. Byddwch yn gallu arsylwi y cyfarfod heddiw, ond ni fydd cyfle i chi gyfrannu. Rydym yn recordio'r cyfarfod a bydd copi ohono ar gael ar ein gwefan yn fuan. You join us today as observers, which means you cannot participate in the discussion. A video copy of the meeting will be available on our website as soon as possible. Cadeirydd y cyfarfod heddiw, Cadeirydd yr Ymddiriedolaeth yr Athro Donamid OBE. Mae 6 aelod annibynnol arall gan y bwrdd, fel y gwelwch o'r wybodaeth a gyflwynir. Today's meeting will be chaired by the Trust Chair, Professor Donamid OBE. As you can see from the slide, the board also includes 6 independent members. Yn ymuno â nhw, mae'r bwrdd gweithredol. Joining them today are the Trust's Executive Board members. Croeso hefyd i Stephen Allen, Prif Swyddog Cyngor Iechyd Cymunedol De Morgannwg, a David Cogan, o Grŵp Ymgysylltu Cleifion Velindre. We also welcome Stephen Allen, Chief Officer, South Glamorgan Community Health Council, and David Cogan, Velindre Cancer Centre Patient Liaison Group member. Mae'r bwrdd yn gyfrifol am reoli perfformiad a strategaeth yr ymddiriedolaeth. The board is responsible for the strategy and performance of the board. A bydd y cadeirydd yn agor i'n cyfarfod nawr. And now the chair will open our meeting.
Prynhawn da a croeso cynnes iawn. Good afternoon and welcome to everyone to this extraordinary meeting of the Trust Board, which is being held in public. We're pleased to confirm that this meeting is being live streamed today and will be available on the Trust website if members of the public or indeed our staff want to view it later at their convenience. So for those of you who've joined the meeting today, and I understand that to be a mix of our own staff and the public, a very warm welcome to you all. This is an extraordinary board meeting, which is being held to discuss the Nuffield Trust advice, which was published last week on the 1st of December on the proposed clinical model that underpins non-surgical oncology in South East Wales. I have apologies this afternoon from Jazz Abraham, our medical director. I'm trying to see, Tom Crosby, welcome Tom. Tom will be standing in for Jazz. Janet Pickles, IM. Paul Wilkins, who's the interim director of the Cancer Centre. And I think we have apologies also from Alan Prosser and Katrina February from Wales Audit. Are there any declarations of interest which are pertinent to the items on today's agenda which haven't already been declared? Just noticing David Cogan there. I want to say welcome to you, David, but you are a member of this of our board, so I don't think to welcome you specifically, but I'm very pleased to see you here, David, this afternoon.
Thank you.
So the item for discussion, as I've said, is the Nuffield Trust advice, which has now been released and published. The Trust undertook a detailed analysis of the evidence informed by engagement with a cross-section of staff and a range of stakeholders across the region. And subsequently, the evidence was considered by an expert panel appointed by the Nuffield Trust, who have a wealth of experience in both health services and in oncology services. When the report was issued on the 1st of December, Velindre University NHS Trust issued a statement to thank the Nuffield Trust for the advice and the recommendations, and we welcomed the report. Since its publication, the executive team has held 3 all-staff meetings, virtual staff meetings because of COVID, obviously, which were open to all DCC staff, and since then they've attended several team meetings as well. The plan for today is that our Chief Executive, Steve Ham, will talk through the paper regarding the background to the project and the summary of the key recommendations, and those are contained in the cover paper which has been issued with your papers. And then we'll have an opportunity to discuss the report in further detail and to ask questions before considering our agreed response. So without any further ado, I'm going to hand over to our Chief Exec, Steve Ham, to present the key findings and to lead us through those. Thank you, Steve.
Thank you, Donna. I first of all, right at the beginning, I had my thanks to those that Donna mentioned, to the Nuffield, was completing this report on time was no mean feat, given the range of people that needed to be involved in the programme of work. So really do express a thanks, and it's really important that timing was kept to as well in terms of delivering the report. Personally, I welcome the report and see it as providing a really helpful springboard for us to take the next steps in the evolution of the organisation and our relationships with our stakeholders. I think that it's already helped us in some of those aspects. I've set out in the report some key aspects of the report for me. It's very difficult to summarise things up, get a few things down, because actually the whole report hangs together as a whole. But I have focused on a few things on there, which I think are really important for us, and I'll dwell on those briefly now. It does conclude that given where we are, something needs to happen now, that we can't wait. And then it also highlights that although there's a trend for co-location, it's not an option for us because for a considerable period of time. And it goes on to explore that later on in the report. It then states the proposed solution that we are working towards can deliver safe and high quality service for our patients. And I think that's a really important position that's set out in the report. It also sees that there are strategic opportunities for us and the region in terms of delivering cancer care in the future that we should consider and work through with our partners in the region. So those are three of quite a lot of things which are in the report, and no doubt we'll get into those as we go through. The next area I wanted to focus on was the engagement we've undertaken since the report. Donna mentioned the 3 question and answer sessions that we've had with staff. There were the best part of 100 people in total attended those over 3 days. And we are now looking at how working with the SMT and the Cancer Centre about how we carry on engaging on the discussion going forward. They weren't ideal arrangements. The Q&As on these sorts of platforms do still the debate a little bit, but I think we did have a really good Q&A session with people, and we didn't load it with the presentations we had. We also met with the consultant body on the Wednesday evening, and there were about 40 medical staff attended that. And I know others, including Nick, have met with senior nurses and individual conversations over the last week, because it is only just over a week since the report was launched, and we attended some other team meetings as well and individual discussions. We've also had LHB engagement. Jazz, if she was here, and certainly Tom would reiterate, we've had a lot of conversations with medical directors over that time and in the build up to the launch of the report as well. So, and I've spoken to each of the chief execs, sometimes with Jazz and the medical directors, others with just the chief exec. It's also triggered, Carl's been talking to the directors of planning as well about how we take the next steps. We started to talk in the report about some of those next steps. There was also a conversation at the Always Medical Directors meeting last Friday. So this report has already got a good airing in terms of our engagement with our key stakeholders and our staff, but that's not reflecting this is the end of that. We've got more to do in terms of taking that forward. We've had some positive feedbacks about the report, and it's generally been very well received in terms of both our stakeholders externally and internally. And that it does reflect people's voice and people reflecting back that it has heard the views that have been raised. It's certainly been embraced in the conversations we've had with health boards, and they're eager to take the work forward that's set out in the report. And we will be taking it. There's just for ease of reference, there's a thing called the Cancer Collaborative Leadership Group, which is chaired by the Chief Executive from Vale, and we'll be taking it formally to that meeting towards the end of January to receive recommendations and work through how we actually go about taking them forward. That's to build on the conversations we've already had, and we have had really good commitment to actually get underneath those things we can't do by ourselves, and we need to do is either an LHP to trust relationship or the system as a whole in terms of defining where we want to get to. So as I said again, we've had some positive internal feedback that people have been listened to. It's a balanced report. It considers the issues that were put before them, and as Donna mentioned, there was a really strong expert panel that supported the process as well. Internally, people are looking for us to deal with the issues that we need to deal with and get on with that. The report sets out some of those. We've established the Velindre Futures model within the Cancer Centre. That's having its first programme board pretty soon. So we're getting on with dealing with that, and the task force leads are feeding into that work and developing the programme and making sure we deliver some of those issues. For us, we need to get on those and make sure we implement the changes that we need to now, and that's certainly something that's been prioritised by myself and the team. At that stage, I'll hand back to Donna to handle the next stage.
Thank you, Steve. Really, our next, I'm just going to ask Tom if you wanted, Tom and Carl, because you've met with individuals outside the organisation since the report was launched, whether you wanted to add anything to Steve's comments. Carl, can I come to you first?
Yeah, thanks, Chair. So just, without going back across what Steve has said, I guess for me, speaking certainly to directors of planning, I guess there's a real desire to really take the opportunities being presented. I think what the report did very well from my perspective, it didn't just look at essentially cause and effect. It could have just focused on the end point, bearing in mind we're at the tertiary end of the pathway, and dealt with just Velindre as an organisation. I think that would have probably been beneficial, but it would miss the real opportunity to start to help us describe how a high-performing cancer system works across South East Wales. So Steve has sort of mentioned, it did start to talk about what does a high-performing system look like in terms of, they mentioned things like an alliance model, a vanguard model, how do we form ourselves, strong leadership, a clear strategy for the next sort of 5 to 10 years, where we can start to make some really well-informed decisions using shared data. So the conversations I've had with the directors of planning particularly has been almost a sense of opportunity and excitement. So almost when can we start? Because many of the things which the report has sort of fleshed out, I think it's fair to say have been sort of fairly long-standing issues. And despite the recent and positive sustained progress over the last 5 or 10 years in terms of cancer services, we all acknowledge that there's more to do. So I would just sort of really support what Steve has said in the general feeling that the report is felt to be helpful for all organisations, and everyone's got a sense of anticipation now that we mustn't lose. So that's my sort of initial feedback from colleagues across health boards I've been discussing with, and also from the conversations I've had within the organisation, this sense of comprehensiveness, this sense of openness, and there are things in there which we can actually get on and do now, and doesn't require any buildings, which might take 5 or 10 years. So I think that's the important message as well. What can we do now which makes a big difference? And then what do we plan for in the next 3 to 5 to 10 years? So I think it gives a nice balance of immediate, medium and long term, which we can all get our teeth into.
Thanks, Carl. It's very helpful. Tom?
Yeah, thanks, Chair. Yeah, no, I'd echo other people's thoughts. I mean, I think, you know, I think my reflection is that, you know, Nuffield went out of their way to listen to as many people as possible. And I suspect disproportionately they listened to people with concerns because they wanted to be heard. And Nuffield didn't back off from listening to anybody who had concerns sort of coming forward. So I think that was very welcome. I think there's lots of sort of thoughts, obviously, you know, about how internally and regionally we deal with this report. But broadly, I would sort of say that the common theme is that it's a bit of a line in the sand, that people had some issues, people had concerns, and they've been able to raise those, and Nuffield have addressed them sort of head on. And obviously one of the main concerns was about sort of co-location, and from the report, and also from a dialogue with the Nuffield Trust, there was a recognition of theoretical advantages to co-locations, to co-locating services, but there was also some I think accepting that in the real world, unless you redesign and co-produce both acute and elective care services from scratch, from a level playing field, not building on existing constraints, there's a challenge. So I think they recognise that just co-locating Velindre on an existing acute site without that acute site being redeveloped would possibly be the worst of all worlds. But they did recognise opportunities for the future in terms of other services being redeveloped, such as UHW over the next 10, 15, 20 years, how we can work together better to use our existing facilities in a more sort of synergistic way. I think I personally reflected during the advice and the consultation of Nuffield that there just is not a perfect co-located medical organizational sort of solution. However big the campus, the village, almost the town of medical services would be, it cannot provide local and it cannot provide tertiary and local provision of services. It cannot provide all services on the same site. There's increasing awareness during COVID and just generally in terms of effectiveness that we've got to separate acute and elective services. And I think the report recognised that. So I think it was a fair and balanced report. What I wouldn't underestimate is the challenge that we have from now, from having this report and however Welsh Government deal with, the proposals of our outline business case. I think the challenge is that they recognise that organisations in Wales are not necessarily functioning together across organisational boundaries as well as they could, and I think we knew that. I think it's given a nudge to the region to come up with proposals and help deliver those models of care more effectively. So I think that's positive. But what I wanted to say is I think it's given a real a bit momentum to Velindre as an organisation to sort of say it has a really, really important role within the region in terms of delivering non-surgical oncology services, but that it has to be done on a networked and linked basis. And I've just had some conversation with numerous colleagues, in the last couple of weeks to say, we can really be ahead of the game here.
Yeah.
Most other organisations have decided on models that try to bring everything together. But if we can really make that networked model work well, that really will give the concept of getting it right first time, seeing the right team locally where possible, centrally where necessary. So I think it's a really, really, exciting time for us as an organisation, but busy time as well, because I think the challenge is there for us to deliver on this now.
Yeah, hold that thought, Tom, because I'm sure we're going to come back to that last point. Thanks very much for that. And I just wondered, a nanosecond warning, David, if you wanted to comment on the reactions you've received to the report, and then I'm going to open it up for questions across the board.
Yeah, thanks, Chair. I think there's three headings from a patient's perspective, albeit as a patient liaison group. We've had a brief conversation. I think the first one is the recognition of needing to do something now. I think, which is foremost in most, if not every patient's mind at the moment. So it's great that the report is challenging and pushing us to do something now. The second point, I think, on the back of Steve talked about engagement, and I think the opportunity to talk to patients. I think there's a lot of description there from Steve of different organisations, people that we've spoken to. From a patient liaison group, we've got a meeting next week. It would be great if somebody was able to come along and discuss with us the report at that sort of more patient perspective. And then the third one, I think, in terms of what Tom's just described, when we talk about reaching out and mobilisation and communication as a patient group, and I think you're well aware, Donna, we're keen to lead as patients. So as we think about local health boards, how can we as the patient liaison group at Velindre start some of that communication with different groups and lead it from a patient's point of view as well as a medical clinical point of view.
Yeah.
So that would be my initial feedback, I think, at this stage. That's
extremely helpful, David, and I'll pick up with Steve and colleagues straight after the meeting about someone attending your meeting.
Great, thank you. Thank you, Chair.
So I'm going to now open it up for discussion. And if you raise your hands that you have a question, and then I'll try and allocate it to the appropriate chief exec. The appropriate exec, sorry. Sorry, Steve. So are there any queries? Gareth.
Thank you, Chair. And it links back to the point that Tom Crosby was making about this being a busy time ahead for the Trust now and others. The report identifies a number of actions for us to take going forward with others. And I wanted to understand whether that would have an impact on the timeline for the development and completion of the new Velindre Cancer Centre.
Who's going to take that? Steve? Or David? David Powell. Thanks, David.
Gareth, that we there's a degree of parallel running here, because ultimately, if we once we've agreed with government the shape of direction in terms of the infrastructure of the building, what we're really wanting to do then is have this piece of work with the health boards to run in parallel. So we want to make sure that as that develops, we develop the infrastructure. So I think they're mutually supportive. So I would say that we wouldn't wait, for example, let's say, to do a year's piece of work on the on thinking through the sort of consequences of the health flows and then get into building. I think what we've asked for from Nuffield is a steer into what we should be doing with the building, which they've given us a fairly, a reasonably clear steer on it, which I think we need to agree with partners. And then also, in order to make that building work, what are the systems that would need to be in place in order to optimise the use of it and the system. So I see there as complementary activities which could run alongside each other.
Thanks, David. Are there any other questions? I thought, Tom, I wasn't sure if you were waving or if your hand was up.
I'm not sure how we're indicating to you, Chair, but
that's fine.
But just to come back, I think also Dave Powell's sort of response is absolutely right. But there's also something, some of the challenges to the system are not anything to do with the new hospital. They're to do with the service model that we have now. We are a standalone cancer centre. If we didn't have a new cancer centre coming in 4 or 5 years, we're going to be standalone for 10, 15, 20 years. So some of the challenges are for us to get on with right now in terms of, how we look after, patients who come to Velindre, how we look after patients who deteriorate with being unwell in Velindre, and how we deliver elective services of chemotherapy and radiotherapy, etc. Those challenges are, for very, very much for now that we need to get on with. I think to come back to David's point, I think Dave Cogan, in terms of, it's really, really important that the patient voice is really harnessed. I think Velindre does pretty well in that regard, you know, relative to other organisations. But I think there's more we can do to systematise sort of patient experience feedback and design of the service. But I think it's also important, and I've sort of seen some presentation from Sarah Morley recently about super connectors. There's also something about us co-producing the solution with our staff as well, and I think you know, that is so important, that our staff feel part of the design of you know, the new world, the new system, be that working differently within our existing infrastructure and Velindre at locations, and also in the future in terms of hopefully the new Velindre Cancer Centre. I think there's something more we can do to really build that vision and implementation with our staff as well.
Thanks, Tom. I mean, from my perspective, I think that the process that we've been through in the weeks leading up to the publication of the report, when we were talking ourselves with staff about what their concerns were, and since the publication of the report, have unleashed a real willingness and desire for everybody to pitch in and be part of the solution, which wasn't so evident before we went into this process. And I've been very encouraged by that. Steve, I think your hand was up. Carl, is your hand up?
A little earlier, yeah, but Steve, go first.
Steve, Carl, Nick and Kath.
Yeah, I'll just say, just for David's information, the PLG is in my diary for next Wednesday, so subject to whatever happens in between, I'm planning on attending, probably virtually.
Oh, great.
No, that wasn't the point I was going to make. I think, Garth, your point is a really important one, isn't it? Because there's a lot going on everywhere in the NHS. We're responding to COVID. We're going to have to catch up and restart and do all those things over the next few years, which isn't going to be a short-term effort either. We are reorganising the way we work and actually looking at management arrangements as well at the same time. And we will be replacing CANISC at a point next year. And that's just some of the things we're going on. So we're going to have to be very smart about how we bring our programs together and join them up. Because if we're not doing that, we'll end up tripping over each other and causing ourselves more trouble. So that's what we're focusing on as an exec group at the moment, and making sure we're absolutely clear how we want things to work, and that we're clear about role and function, both between CANISC implementation, service change, and the management arrangements we're putting in place, alongside the work of David's team that are running on the hospital and bringing those even closer together than maybe they have been. So that's the internal stuff. And then we're going to be talking across the region about how we work. And the challenges in the health board are probably even bigger.
Yeah.
But the energy at the moment that's been created has been significant. And I think, as Carl and others have mentioned, we need to harness that. There's a real energy about sorting some of these things out. And we need to build on. One of the things I meant to mention when I was talking was the work that's gone on over the last 12 months, which has been a little bit unseen, and I think David might have been part of, around the acute oncology service, will land with a business case in January. And that's one of the areas that we're challenged to sort out as a region. So we're proving to ourselves that we can. And it's been a fantastic piece of work. We put some joint leadership in with others across the system, and we need to use that as a means to prove to ourselves that we can actually make change happen.
Thanks, Steve. Carl, I'll come to you next.
Yeah, thanks. It's just building on a couple of the points and answering, sort of picking up Gareth's question, really. So I guess I'm going to be a bit boring. I know that understandably the focus has been on the new hospital, because that's the big thing, isn't it? But I think, go back to what we're trying to do here. We're trying to redesign a service. And I think actually I just wanted to give people the assurance that we've already got a lot of these plans and arrangements in place. I think the Nuffield report has done two particular things. One is just reaffirmed our direction of travel is the right one, which is important. And second, it's given us, as Steve and others have described, a real opportunity to bring some of those sort of more wicked issues together in a consolidated manner. So we can always improve our plans. We can always get, in an ideal world, a bit more resource. But I did just want to give the assurance that most of these things are actively in place now. And I think what this will help us to do is to actually generate a bit more momentum and a bit more critical mass across our organisation, also the region. Of course, that doesn't at all, notwithstanding the other things we have to do. But I just wanted to give the assurance that those things have been in place and working for 2 or 3 years. I think now we need to see them through to conclusion, and then actually, more importantly, realise the benefits for patients, for staff, for wider partners of the things that we're trying to do.
Thank you, Carl. Steve, before I go to Nick next on the list and then Kath, I just want to, you mentioned COVID and what's going on in the health boards. We know that COVID is placing enormous strain on the whole NHS system in Wales and the social care system and so on. Everybody's working extremely hard. Do you think that will affect the ability in the short term for our health board colleagues to be able to engage with us on this programme of work, or might we have to be a bit patient? And if we do have to be a bit patient, what effect might that have on our timelines?
Well, first and foremost, the work we need to do is we need to sort our own organisational issues out, and we need to grab hold of those, and those within our gift to prioritise. I think it's bound to be an impact. It would be wrong of me to say that there won't be some sort of impact. All I can say is the response we've had over the last month or so has been very engaging. The conversations have been very strong. I think it gives us something to work off. But we're all going to face real challenges both in the coming months and over the coming years around COVID, and we're all going to have to plan within that environment. But I'm encouraged by just the conversations we've been having today. It has just brought conversations out that we haven't been able to have before.
Thanks, Steve. Tom, did you want to come in on that point specifically?
Yeah, specifically because there's lots of conversations we're having nationally at the moment around COVID and potential recovery plans, and Scotland have issued theirs just in the last few days, and we'll certainly be having conversations with Welsh Government about what our recovery looks like in Wales, but reflecting that back onto the organisation, I do think it's really, really important that wherever possible we do what we can do best, and only we can do, and that is the safe delivery of elective care, radiotherapy, chemotherapy as well, and looking after our patients who have complications of treatment, particularly if and possibly specifically, Nick can comment, if they're not related to COVID infections. So I do think, Velindre, people are looking that there almost certainly will be some form of cancer COVID recovery plan, and I think Wales will look to Velindre to say, as a leading cancer organisation, how are we leading our component of it, and possibly something wider as well, but certainly our component of the recovery from COVID. We've got a cancer summit coming up in a couple of weeks with Simon Dean, and presenting there is the backlog of patients who are undiagnosed or coming through slowly, or and it's frightening information. And I've just come from a call from the diagnostic community who are really doing something quite transformative in terms of working differently, but that is all going to come to us in time, as part of a non-surgical provider organisation. So we do need to really prepare for that as an organisation.
That's very helpful, Tom. Thank you for that. Nick, finally got you.
That's okay. Thank you, Chair. And I do certainly concur with everything that my colleagues have said. Clinically, I think it's a really exciting time for us at the moment, and certainly, the clinical elements of the report that were identify things like the admission criteria, just to provide board members with assurance that that with areas we have been working on with our clinicians. And since receiving the report, I've met with a whole host of different professional groups and in large numbers. They all welcome the report, but actually there's a real excitement now about transformation and and how they are energized and want to help us shape this for the future. So of course, it's going to be a challenge in the current climate, but what I'm seeing, feeling and hearing is clinicians of all professional groups from the Cancer Centre are actually wanting to work with us. So we have a real multi-professional, drive, for shaping the clinical model. Yes, now in the medium term, but also for the long term for the new hospital. So I think it's a really, really exciting time.
Thanks, Nick. That mirrors the impression that I'm getting as well from my sort of perspective and the people that I come into contact with. It's which is excellent. Stephen, I was trying to. Can I see everybody on my screen?
So Stephen Allen did raise his hand earlier, Donna.
Yeah, I could see. I saw Stephen Harris and then Stephen Allen, but I'm just. Lauren, can I see everybody?
I don't know.
If you can't be seen, be heard.
Yeah, you have to shout out if I can't see you, but you know I can't see. Anyway, Stephen Harris and then Stephen Allen.
Hey, thank you, Chair. Obviously, a good moment for the Trust and an opportunity to look forward now to delivering this agreed clinical model. But I just want to spend a few moments actually looking back. And I want to start looking back when I joined the Trust in April 2017. And at that point, the Trust was actually well into what I would call quite a comprehensive, well-structured engagement process with all sorts of individuals and organisations about coming up with the clinical model that would then inform our plans and inform, for example, the design of the new building. So that rolled on quite appropriately, very, very comprehensive, involved our staff, involved various organisations, involved staff across the network, involved patients, involved the public. And after about 2 years of work, as I recall, we came up with an agreed clinical model. That came to the board, was approved. That then formed the basis for our plans. So now we roll on a couple of years, and Nuffield, in a sense, they're not reviewing what we presented before. They're reviewing the situation in the round, but they have actually come up with a slightly different clinical model. Without wanting to dwell too much on the past, I suppose I would certainly find it helpful, and perhaps other board colleagues would, just to try and understand how it is we've ended up in a situation that within a relatively short time, there's a modification required to the clinical model that was come up with 2 years ago through a very comprehensive process. So, as I say, there may be all sorts of explanations, but I'm keen to understand whether perhaps the process wasn't as robust as it could have been. Did we not involve everybody we could have? Has it just things have moved on clinically, or is it just increased pressures or enhanced expectations in the system? So I don't want to introduce a negative here, because there's lots of positives, but I think there may be something we can learn also by looking back at where we've come from, as well as looking forward to where we all want to get to collectively. So I don't know who best to direct this to, obviously the execs, Steve or Carl or somebody.
Shall I start on it?
Steve, okay, thank you.
Just say, I mean, there's always something to learn, and I think this is a really important one to pick up. And this sounds like a very glib phrase. And maybe Kath was wanting to come in on the earlier discussion. She would talk about where we're heading with Velindre Futures, which is really all those things you talked about on an ongoing basis, and making sure it becomes a core part of our ethos as an organisation, Stephen, as opposed to, because we moved on to the OBCs and we got this and we got that, and then we're now coming back to the clinical model. It will move, which the report says. It's not a static thing. It does challenge us to have it under review. And I think that's not just a challenge for us, that's a challenge for the system. And we all know that's a bit of a struggle sometimes because of the pure sheer volume of what we're trying to achieve. But I think it's an important challenge in the report to not stand still, and we certainly determined as a team that that's the nature of the organisation we will be. And I'm sure Tom will want to come in on some of that.
Carl's got his hand up to respond. Shall I come to Carl first and then yourself, Tom? Carl.
No, I'm going to do the clinical bit, that's for sure. So no, I think it's really it's a really good question, Stephen. And again, I've got to just check that I'm not being subjective either. So I think that's important. But I think if we just go back to almost first principles, and what we were describing was patient-led, patient at the centre, actually equitable care, consistent wherever you receive that care. So we start with the principles. I think the principles are still right and sound and still stand. And then the sort of model. So we said more patients where appropriate and through their choice want to be receiving care in their homes. Then doing more in a local community. And then finally, you'd have to travel a bit further for specialist care. So again, I think those are still sound and right and proper. I guess the thing which we were already working on, the question in the report was, which patients should be admitted where for what purpose? We were doing that work anyway, because that was irrespective of the report. And I guess the bit for me was, it's forced us into the things we were doing anyway, but accelerated. So the things which are highlighted in the report, there are many, but ambulatory care and how that relates across the region. Steve has touched already on the importance of acute oncology services comprehensively provided. Trying to get a sensible conversation about hematology and oncology, how do those things come together? And I think the thing we haven't talked about today, which is particularly important and almost the forgotten cousin, is research, development, innovation. How do you make that part of frontline service delivery? Because we know that good research, good development actually informs the future, but also ensures that clinical practice improves and delivers better outcomes. So I am trying not to be too subjective, because I know I've been close to this, obviously, but I think your question, I think, subject to other colleagues and other external views, I don't think we're still on the right track, and I don't think an awful lot's changed other than the things which will make it better.
Yeah, well, that's helpful. Thanks, Carl. Kath, I think I overlooked you, didn't I? So can I do Kath next and then Stephen Allen?
I'm more than happy to let Stephen go first, then maybe I can summarise some of the things we're taking forward with the Velindre Futures, if you'd like, Chair. I'm happy to do that.
Okay, thank you, Kath. Stephen?
Thank you, Chair. I just wanted to flag up, I've obviously seen the Nuffield report and circulated that to my colleagues across Wales, across all CHCs. I think it does set a blueprint as to a way forward, perhaps for the way cancer services need to be looked at going forward, which I think we actually welcome. But I just wanted to, and again, not mean to be negative, but obviously you would expect me to raise concerns on behalf of the wider community and patients. And that is obviously the Nuffield received all the information in order to undertake this review. Can I just check, please? And I know there's a correspondence you've had from a concerned member of the public raising a number of questions, which links to the meeting today, really, because obviously you've now received the report. So I'm just seeking assurances that Nuffield received all the information contained within that correspondence received by your trust board at the end of November, prior to their review and to them reporting against that, and all that data was made available to them, including letters from clinicians as well as the other items which have been identified. The reason being I'm asking that question is obviously there's a requirement really for us to make sure that we have that assurance from you that was undertaken, on the grounds of obviously that would then help, one, to answer the questions flagged up legitimately by a ex-service user and also by the patients and the wider community. It would also give us the assurance as well that actually that the Nuffield actually undertook their review having access to all that information.
Thank you, Stephen. One of the things that I know for sure is that those who, when the Nuffield were discussing the kind of people they wanted to interview, in their categories was those who had written letters of concern to either ourselves or to Welsh Government or wherever, that they were included in the people that were to be invited to interview. Looking at Lauren, perhaps if you can clarify that, that was definitely the case, wasn't it?
Yeah, that was the case. And those letters of concern were shared up front with the Nuffield Trust, which actually helped them form the terms of reference that then structured the work. And when they were then requesting who they wanted to interview in that stage of the process, as the chair said, they specifically wanted to talk to those who had led on the letters of concern as well.
Does that answer your question, Stephen?
It does answer my question to a degree. Obviously, I know there'll be a formal response to the communication that you've had, and I know the CHC will be seeking to have that assurance as well, if that's at all possible, from the Trust Board, that actually that we could be satisfied actually that due diligence was undertaken. That's what I'm seeking really from you today.
Thanks. And we also, through the Nuffield, arranged sessions toward the end of the interviewing phase, open meetings where anybody could book in and have an interview with the Nuffield. So that I don't think we left anybody out that they'd asked to see, but then we did. There were 2 days where people could just book an appointment and have an interview.
Okay, thank you, Chair. That's much appreciated.
Kath, I can't see any other hands up.
Thank you. I'd just like to bring together a number of themes.
I'll come back to you, Martin, in a sec, okay? Sorry, Kath.
That's okay. I'd just like to bring together a number of themes that we've discussed in the last half an hour or so. I think we've touched upon the enormous amount of engagement that there was a couple of years ago, and the amount of work that has been ongoing in the Cancer Centre since that time to look at how we develop our services on an ongoing basis. We've also been doing some work, as Steve pointed out, to restructure our management team within the Cancer Centre. And back in the summer, we established the Velindre Futures programme in its initial phase that started looking at our admission criteria, as Nick has mentioned, around some of our patient pathways, around some of the education elements in terms of how we're able to support ongoing training requirements for our clinicians, and also looking at our research and development aspirations. So all of that work is coming to fruition in terms of making some recommendations, and we're working hard to make sure that we maintain the momentum that has been gained through that process, and we take it forward now through to the delivery phase. So that work is progressing well, and we'll be holding the first programme board for that in early January. And when we have our next opportunity, I'll be able to provide you with some more details on that. But one of the other important elements that cuts across to the suggestion that David was making around engagement with the patient liaison group is that since that time, we've also been having discussions with the patient liaison group about how we systematise the engagement and activities with members of the public, with patients and their carers and their family, to make sure that we're able to ensure that their input is targeted just in the right way and at the right time into all of our service change aspirations. And we've had some discussions about that as an executive team this week in terms of how we're going to be able to take that piece of work forward over the forthcoming months. So on Wednesday, I'll be bringing the latest update on that to the patient liaison group. I look forward to having some more discussions there. So just to provide you an assurance that the enthusiasm and the increased opportunity for constructive discussion is really being capitalised on as much as we possibly can. And although we recognise the fact that everybody's very tired from all of the activities, endeavours in this pandemic, that actually that doesn't seem to be denting everyone's enthusiasm and willingness to actively engage to make sure that we're able to really keep taking forward all of these endeavours. So we look forward to providing you with some more information when we meet again next time. But just to give you that assurance that that things are all moving in the right direction and with pace.
Thanks, Kath. Thank you very much. That's very helpful. Martin.
Thank you, Chair. I guess I want to contextualise this in terms of the whole system of anti-cancer treatments. I mean, this isn't about building a new hospital to solve all our ails. It's about fitting that in within the totality of what anti-cancer therapies means going forward. Particularly with the backdrop of COVID and the lack of referrals that have been coming through cancer services and the potential backlog that's out there in the world, and that's coming our way. The solutions aren't in our gift, and as Tom has talked about the network really well. I guess the obvious question as a result of this whole program, this whole report, is what does it mean for us? Is it going to significantly change any of our plans going forward? And sort of, I guess it's a so what question.
Thanks, Martin. That's a killer question for the end. I think Steve would be probably the best person. And if I can, just as a starter for 10, Steve, say, one of the things that we most welcomed about the report was that it held a mirror up to us in terms of what we were already doing and planning to do, which was very reassuring. Having said that, Steve, I'll hand over to you to answer that.
I know others might want to come in or not, but I think long term, I don't think it does change anything, Martin.
Yeah.
I think our ambition's the same because the service needs to be where we're going in the long term. Over the short and medium term, it puts greater onus on us, I think, to deal with the here and now issues. And certainly the team are really focused, working with the SMT and the Cancer Centre, but making sure we deal with those issues. This actually puts us in a better place to deal with the things that are going to come. It's going to be up and down. It's going to be tough. We know it will be tough over the coming years, and we're going to have to respond to it. But the long-term plan, I think, it doesn't change. The model of the service, Tom mentioned, some people call them hot and cold sites, others call them green and red sites. I think it's an important thing. We know where we've been over the last 6 months. We're trying to keep our site green as best we can in a very difficult circumstance. And I think the sort of model we're now talking about in the Nuffield have supported, I think helps with that. So I think that reaffirmation, I think it reaffirms with our long-term plan, which should remain our focus.
So I'm going to conclude in just a moment because we're coming to the end of our time. But before I do that, I wanted to ask you colleagues if anybody wants to raise any questions or come in. Hilary, was that your hand up?
Yes, yeah, it was, Chair.
Yeah,
thanks
Hilary.
for that. Yeah, thanks for that. It's just more of a comment, really. As somebody who wasn't around when the initial consultations and the discussions and the decisions were made by the board 2 years ago, I think for me as a board member, what this report has done is sort of reassured us that the direction of travel that the board made then is just as relevant today as it was then, but it's just given us the opportunity with more, as things naturally change and direction changes, there are recommendations there for us to take on. I think it's all very positive and it's all an exciting time. So I think it's been a really positive report.
Thanks, Hilary. So I'm going to conclude. Let's be under no illusion that there's a lot of work ahead of us in order to fulfil the recommendations as set out in the advice that's been given to us. But given the content of that advice, our discussions today and the responses that have been provided by the officers, it's my intention now as Chair to ask for us as a board to support the recommendations set out in the advice from the Nuffield Trust and to support the direction of travel with respect to the next steps laid out in the covering paper to the report. And in doing that, we should acknowledge that this is going to require continued close partnership with our staff, our patients, the Community Health Council and our health board partners to ensure that we end up with continued delivery of excellent cancer services to the people of South East Wales. So colleagues, I'm going to ask you now if you would, with a show of hands, demonstrate that you welcome the report. Do you all welcome the report? Thank you. Do you support the recommendations set out in it? It's a majority. And do you support the direction of travel with respect to next steps, which are outlined in the covering paper? Thank you. So that concludes that item. I haven't been informed of any other business. I'd be surprised if there were, because this was an extraordinary board meeting for this particular agenda. And date and time of our next meeting will be Thursday the 28th of January from 10 to 12:30, which will take place using Microsoft Teams again, but who knows where we'll be by then. The vaccination won't have been rolled out completely. It'll be well underway, but it won't be rolled out completely. So I suspect we'll probably still be meeting virtually. And for those of you I may not see again, can I just wish you all a delightful festive season and a happy Christmas.